Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Hey, how are you, John? Good afternoon or evening.
Hey, Jay, how are you? You doing all right?
Good. Yeah.
Awesome.
Yeah, we're definitely in the throes of winter. It's dropped into the 50s here. Gotta get out all my parkas.
Yeah. Go ahead and get your snow shovel out and all that. Emergency cold wave coming to California. I love it. I love it.
Yep.
Hey, December, the last month of PharmaDocs.
I know. Can you believe it's December?
But guess what? New drugs, Jay, always get approved.
Always.
So there'll always be a PharmaDocs, right?
Yeah. Yep. New drugs every month. And I think they were with their
colleagues. Who else do you want to learn from than practicing dentist? Okay. All right. I mean, we're in the trenches every day. We're here to make you a better practitioner, period.
Yep. That's all we care about.
And go back and look at all of our different segments. You're going to learn about medical emergencies, medically compromised patients. You're just going to be a better clinician every day in your practice. And that's all we want. Period.
And a better person for it too.
Yeah.
All right. So let me bring in our slides here. Oh, wrong button. Sorry. There we go.
Highlight on Dr. Reznick here. Here we go.
Okay. Hit the right button this time. All right. So today's December 8th, and we are the PharmaDocs.
We are the PharmaDocs. That's
and
right.
Of course, we want to start off by thanking our sponsors. First is iCore Connect and their product iCore RX, which is a electronic digital prescription platform that allows you to prescribe medications for your patients from anywhere at any time, laying on the beach, sitting in your office, hanging upside down in the backyard, doesn't matter. You can, as long as you have your phone with you or your laptop, you can send in a prescription.
You got it.
Send in a prescription. Right. And Fortune Law Firm, who basically helps you keep the money that you earn. They get involved with your estate planning, with your different insurance coverages, financial support, and of course they set you up so that you can keep the maximum amount of the money that you earn. And should you have an adverse effect or adverse incident in your office, they will be there to, in addition to your liability company, to really help you get through it and protect your assets.
Absolutely. License protection.
Yeah.
And let's not forget about the Vesper Institute.
The Vesper Institute in Cincinnati, Ohio.
The Midwest Center of Dental Education.
Yep. At which John and I are both on the faculty, and we'll tell you about one of our courses. We've got a couple coming up there for 2024, but we'll save that to the end. Save the best for last. All right. So we don't have any medical news or drug news this month, or at least in November. So we'll get right into the drugs. And the first one is Voquezna or vonoprazan.
Vonoprazan. That's right.
So this, I think, is one of the first potassium competitive acid blockers for the treatment of erosive esophagitis. So, we used to have originally the H2 antagonists like Pepcid and Tagamet, and then they came out with the protein pump inhibitors, like Prevacid and Meprazole. So this is a little bit different mechanism for reducing and helping protect the esophageal mucosa. And it's indicated for treating all grades of erosive esophagitis and heartburn, which basically is an effect of gastric reflux, of GERD. And the acid splashing through the lower esophageal sphincter and getting on the esophageal mucosa where it's not supposed to be. You're not supposed to have low pH fluids in that area.
Right.
The lower esophageal sphincter is supposed to protect the esophagus from the gastric acids. But when this happens, patients get heartburn, and it can be just due to acid alone, or it can be due to a bacterial infection. Most commonly, Helicobacter pylori, which,
yes.
when I was going through school, they didn't even know that that peptic ulcer disease and esophagitis was related to bacteria.
H. pylori wasn't even being discussed.
Yeah.
All right.
Well,
and so they got the triple cocktail, which you're probably about to talk
ulcer?
about.
That was kind of new, but so Helicobacter pylori is basically a bacteria. They're kind of cute. They look like little I don't
know, little octopi.
Yeah, little squids. They look like little squids.
A little squid, yeah.
And when they colonize in the stomach or in the esophagus, they cause more irritation, which allows the gastric acids to cause a lot more damage because they're now being constantly irritated. And so with GERD, you're losing that protective mechanism of the normal esophageal mucosa. And if this goes on unchecked, then the patient can go from just a basic, we'll call it grade A, just kind of a minimal isolated form of erosive esophagitis, all the way up to grade D, where you've got erosions basically at least 75% around the circumference of the lower esophagus. And, this constant irritation in about 15% of patients who have erosive esophagitis develops in what's called Barrett's. Barrett's esophagitis. And what it is a metaplasia of the normal squamous cells in the lower esophagus to these columnar cells. And these columnar cells have a potential for changing into esophageal carcinoma, most commonly adenocarcinoma. So this is not, just an irritation from, gastric contents. It can lead to esophageal cancer, which can be pretty nasty because most of the time it's not diagnosed until it's in stage 4.
Yes.
So it's not diagnosed very early at all. So this Voquenza, the way it works is by blocking the potassium competitive acid blocker for erosive esophagitis. Whoops, let me go back there. 10 to 15% of GERD patients will then progress to Barrett's metaplasia. So that's not an insignificant number. That's why this new treatment modality is so important. All right.
Well, they had patients on lansoprazole instead of omeprazole, lansoprazole. And so when they put them on Voquenza, they had much better results.
Yeah.
And so what we're seeing here, Jay, is another type of you talked about the protein pump inhibitors. Now we've got this new potassium competitive inhibitor as well too.
Yeah.
So it's going to be very interesting to see all of the various indications for this drug as well as off-label use. This may be the first line for just going straight for GERD. All right.
Yeah, possibly. And the medications out there are getting better and better. They're getting more specific for the disease they're treating with not as many side effects, although, all these drugs have side effects. And one of the big ones with Voquenza is the development of C. difficile overgrowth in the intestine and pseudomembranous colitis, which is, not something that you would like your patients to have.
No.
More commonly, you get things like diarrhea, gastritis, abdominal distension, those kind of minor things. But for the most part, this is very effective not only for treating erosive esophagitis, but also for keeping it in check for the long term.
Yes.
So, all right. So our next drug is Zituvimet.
So one other thing about that, so, your physician or your GI doctor is going to have either the dual pack or the triple pack.
Oh, yeah.
That he or she will discuss for what's best for you if you're diagnosed with H. pylori.
Right. So what it is basically the medication along with either one or two antibiotics, either amoxicillin and clarithromycin, or just amoxicillin with the vonoprazan. Okay, so let's move on to Zituvimet, which is a new combination drug.
Yeah, and again, it's for diabetes, and like every month we have something for diabetes or ulcerative colitis or some type of metastatic carcinoma. And so this is right in line, Jay, with what we're seeing.
And this is a combination drug, so it combines metformin, which is a biguanide that's been around forever. With a new DPP4 inhibitor. And so the combination of the two together seems to be much more effective than either drug alone. And just to kind of remind you how what the DPP4 medications do is they will. Can you see my pointer, John?
Looking. I do not see it. No.
Okay. I guess. Okay. Well, I guess it doesn't translate then. So DPP4 inhibitors like Januvia, Tradjenta, what they do is they inhibit the breakdown of GLP-1. So they're raising the level of GLP-1, and so that leads to more insulin being produced by the pancreas, less glucagon being produced, and also delays gastric emptying, so that the carbohydrates, the nutrients in the stomach and the GI tract are not absorbed as quickly, and the result is a lower blood sugar as well as weight loss because the patients feel fuller all the time because of the delayed gastric emptying. So this is an interesting combination drug, and so I think we're going to see a lot more of these combinations coming down the road.
Absolutely.
So just to kind of remind you, there are two types of diabetes, type 1, type 2. Generally, the type 1 is what we used to refer to as juvenile onset, and that's usually due to an insulin deficiency, a deficiency in insulin production, versus type 2, which is more of a resistance to insulin so that the glucose can't get out of the bloodstream and into the cells. And both of these can lead to a lot of severe problems. Type 1 diabetics are generally on insulin or some type of similar medication to reduce their blood sugar. And type 2 will be on something that increases either the production of insulin or increases the sensitivity of the cells to that insulin. Right. And of course, we know both diabetics, especially if it goes on for a long time, are susceptible to a lot of different types of sequelae, a lot of other diseases that it causes and problems that it causes. And so we'll see in patients with type 2 diabetes, especially because these patients are generally more overweight and sedentary. They tend to fall into obesity where their BMI is over 30. They have hypertension. They usually are, eat all the wrong foods. They're stressed out. They, drink a lot of alcohol, and it raises their blood sugar, which leads to all these other complications, as well as diabetic peripheral neuropathy, retinopathy, and all kinds of apathies. All right. Anything else to add on Zituvimet?
Yeah, think about it, Jay. You touched on the GLP-1 inhibitors, and of course, the one we saw down there was Ozempic, and of course, that's making the news. There they are, right there, and of course, all of those are injectable except for Rybelsus, which is the PO form of that as well too. And so, our biggest concern about these medications, if you're putting people to sleep, is that delayed gastric emptying. Okay.
Yeah.
So you've got to be cognizant about that and remember that this does affect the GLP-1 sites right there.
So whether you're doing oral mild sedation, IV moderate sedation, or general anesthetic or deep sedation, they have found, and there's a lot of information on this in the recent anesthesiology literature, that they have people that had food in their stomach 2, 3, 4 days after they stopped eating.
Yes.
It could, because of the delayed gastric emptying. And so the recommendation with these medications is that they stop them at least a week before any surgery where they're having some type of sedation or anesthesia.
Yeah. So the week that your normal dose a week before the surgery should be stopped.
Yeah, exactly. All right. Next one is Fruzacla.
Fruzacla.
Seems like there should be a U after that Q, huh?
Fruzacla.
Yeah. Right. See, on the generic name, it has a U in there.
So here we go. So we got another drug.
Yeah. Which is frujuintinib, which of course is an inhibitor of something, and it's a highly selective inhibitor of FR1, 2, and 3 for treatment of previously treated metastatic colorectal cancer that is not responding to the typical treatments. And so this is a new drug in the arsenal for trying to get metastatic colorectal carcinoma under control. At this point, it's usually pretty far advanced, but it can delay the onset of metastases. So on this diagram here on the upper left, that is a polyp, and that's usually how a carcinoma develops. That's why, after the age of 50, or now they're recommending 40, you want to get a colonoscopy, because if they see a polyp, it's benign generally when they see it, but if you leave it, it can develop into a carcinoma, and so they will remove the polyp or any polyps that they see, and maybe see you a little bit more frequently, like every 5 years instead of every 10.
Yes.
And then, of course, you can get carcinomas developing in anywhere along the GI tract and in the rectum as well.
So the thing about it, Jay, is like your slide right there, the metastatic colon cancer. You can go ahead and advance that. So what is the definition of that? Well, the cancer originated in the colon or the rectum area, then it's spread to other parts of the body, which the graphic that you have right there, it could be the liver, which is so devastating to these patients, bone, the lungs, and of course, the brain itself as well, too.
Yeah.
So when it starts getting like that, like you just mentioned, we're in the end stages right there. Right. So having a drug like Fruzacla is a great new drug to have in the armamentarium.
Yeah, when it only exists below the diaphragm, that's still stage 3. But when it's on above the diaphragm, that's when it's considered to be stage 4. And one of the places that colon cancer will metastasize to are the bones. Wild animals in here. Yeah.
A new guess.
Well, the bones, and one of the drugs or classes of drugs that are given to patients that have metastatic colon cancer, as well as the other types of cancer to the bones, are bisphosphonates and some of the other the anti-angiogenics. And so if you've got a patient with metastatic colon cancer, you got to make sure you know whether they've been treated with bisphosphonates or not. Because that, of course, if you're doing something in the jaws, an extraction, periosurgery, endo, whatever it may be, they are, potentially setups for MRONJ, medication-related osteonecrosis of the jaws. So that's always something that you guys got to keep in mind. And let's see. So it works it's an inhibitor of the vascular endothelial growth factor receptors. So it inhibits VEGF-mediated endothelial cell proliferation and tubular formation, and has been found to prolong survival in patients with metastatic colon cancer for around 8 to 9 months, depending on the dose it's given and what stage it's given. All right, our next drug.
And guess what? We just talked about using these medications for weight loss, and here it is. In fact,
here it is.
We touched on this last month, Jay, briefly about tirzepatide and or called Zepbound as well too.
Yeah.
And this is, it's not for diabetes. It is strictly for weight loss.
Right.
Okay? It's the first drug came out with its indication for weight loss.
Yeah. Ozempic, that was an off-label use for weight loss.
Yes.
I think now it is on label, or is it still off-label? Yeah. But this is the first one that's come out that is the indication, the approved indication is for weight loss. Yeah. And of course, it's got to be used, not by just give someone a wonder drug, but you have to change the patient's lifestyle. You have to get them to change their diet, eat less, eat healthier foods, increase their physical activity. Otherwise, they're not going to get better over time. They're not going to lose. They're going to lose some weight, but it's going to come right back.
But Jay, I've seen people on interviews talking about, hey, I'm on this drug or that drug, and I haven't changed my lifestyle one bit, and I'm losing weight. Well, as soon as you get off the shot, guess what's going to happen? It's going to be
right back.
If
you don't change your lifestyle and your diet, that's what's going to happen.
And I hope these drugs would do that, Jay, would get people to where, hey, it's giving me a good kickstart. I'm going to change my lifestyle, and then eventually get off this medication as well, too.
Exactly. And so as far as its indication primarily for weight loss, for patients who have a BMI of over 30 kilograms per square meter, which, by the way, is about 40% of the U.S. population,
40%,
with no comorbidities, it's indicated for them. Or if they do have hypertension, diabetes, sleep apnea, cardiovascular disease, then the threshold is a BMI of 27 to give the patient this drug. So I think we're going to see a lot more of these.
Absolutely.
In the future.
Because the bottom line, they're going to decrease food intake and delayed gastric emptying, period.
Yeah. And so remember, again, you got to keep in mind the delayed gastric emptying, if you're doing any type of sedation, even oral, is something that you have got to be on the lookout for. Otherwise, you could end up with an anesthesia or sedation disaster in your office.
But Jay, one of the studies on this drug was absolutely phenomenal. Okay, so people that were taking Zepbound at its highest dose of 15 milligrams lost, on the average, Jay, 48 pounds.
Wow.
Whereas people on 5 milligram lost 34 pounds, and on placebo they only lost 7 pounds.
Yeah.
Unbelievable.
And this is like Ozempic. It's a weekly injection.
Yes.
But there is an increased risk of thyroid C-cell tumors with this drug. So that's under the a boxed warning.
Yes.
Typical side effects are nausea, diarrhea, vomiting, constipation, abdominal pain, indigestion. All the common GI side effects, as well as GERD.
Yeah.
So obesity is a big problem in the U.S. It causes a lot of morbidity and mortality. And like I said, it's an epidemic in this country, and it's about 40% of our population. And in some areas, it's more than 50%.
Yeah.
I mean, you can't walk 10 feet without seeing someone with a BMI over 30 or even 40.
Yeah.
And these people are just literally a ticking time bomb for all kinds of problems: heart failure, high blood pressure, various cancers, asthma, diabetes. And so it's, this is a societal problem that, especially, and they're blaming a lot of it on processed foods and fast foods that we need to get control of if we want to have a healthy population. And so the other things it can lead to is obesity can lead to sleep apnea, very, very common, hypertension, osteoarthritis. And it's not that the obesity affects the joints, it's because there's so much weight being put on all the joints. So just imagine someone, if you're walking around with a backpack with 50 pounds of rocks, okay? After a while, it's going to start wearing on your hips and your knees and your ankles and any other weight-bearing joints, and can lead to total destruction of these joints.
So bottom line, when that obesity or obese patient walks into your office, that's a patient red flag, period. Yeah. All right. Yeah. Because they are going to probably be involved with metabolic syndrome. All right. Obesity with 2 or 3 more disease states.
Yeah. Yep. Exactly. So let's see. Anything else on this one? No, I think we'll move on to the next one. Adzynma. Where do they come up with these names?
It's you would think there would be some correlation or close relation to the disease itself, but it's not.
Yeah,
nowhere near it.
Yeah, I think they just like put a bunch of syllables and they throw darts and see what kind of name it'll make. So this is a disintegrin and metalloproteinase with thrombospondylin motifs 13.
That's where they
RADAMTS13, which is a mouthful in itself.
Yes.
And so what the drug is indicated for is treatment of thrombocytopenic purpura, especially the congenital type. And so with TTP, what's happening is the circulating von Willebrand factors, which normally are going to be cleaved into smaller segments to work normally, are not cleaved. Looks like a robot with his scissor arms cutting the von Willebrand's factors. And so what this will do is interfere with normal circulation. It'll prevent clotting because a normal von Willebrand factor is necessary for normal clotting to occur. And it will also, these big proteins of von Willebrand multimers can also collect platelets and cells and lead to all kinds of problems like microscopic vascular disease. And what you see in a lot of patients that have TTP is this is what thrombocytopenic purpura means. Not enough circulating or functional thrombocytes leads to purpura, which is basically a vascular rash like this. And, you have to be really careful with these patients to make sure that if they need replacement of any factors, you want to be sure you speak to their hematologist before you do any kind of surgical intervention on these patients. And so it's, there are so many medical disorders out there that really affect what we do in dentistry on a daily basis.
Yeah.
So, all right. The common adverse reactions from this are headache, diarrhea, migraine, abdominal pain, nausea, respiratory infection, dizziness, and vomiting. It seems like every drug has those side effects, doesn't it?
That's the common ones for sure.
Yeah. Yeah. All right. So our next drug is DefenCath.
What a name. Guess where that works, huh?
Yeah, it works on catheters. So patients who have chronic renal disease and are on chronic hemodialysis, they a lot of times will have a central venous catheter. So it goes into a deep vein, like the vein in the leg, saphenous vein. It can go into. They can have they may have a shunt. All these deep, basically deep, large veins. And when you stick a catheter in there, there are a lot of things that can introduce infection. They can have, if the skin wasn't cleansed enough, if the catheter for some reason gets contaminated before it penetrates the skin, if you're not using sterile gloves to place the catheter, distant hematogenous spread from other infections in the body. It can all cause contamination of the catheter and lead to severe bloodborne infection. And so what this drug does is it let me flip this over, is it is used in combination. So it's two drugs. It's both taurolidine, which is an antimicrobial, not an antibiotic, but an antimicrobial. And it works by attaching to microbial cell walls and causes a loss of cell wall integrity to destroy the bacterial cells. And then, of course, heparin is an anticoagulant that is used with patients every time they have anything administered through their catheter. They flush the line with heparin so that they don't get a blood clot forming in the catheter, because you don't want to form a blood clot and then push it through and get a pulmonary embolus or stroke or MI because of a thrombotic event. So this is a wide spectrum medication that reduces the risk of catheter infection by about 71%.
Impressive.
Yeah, very impressive. And so the common reactions are nausea, vomiting, dizziness, but also musculoskeletal chest pain, thrombocytopenia, catheter malformation, and bleeding. Our next one is Augtyro, or repotrectinib. Why don't you take over this one?
So we know that's another type of inhibitor, which is a TK inhibitor, TKI, which is a tyrosine kinase inhibitor. And this is for the treatment of non-small cell lung cancer.
Yeah.
All right.
And do you know what the ROS stands for?
The ROS should be
ROS?
Enlighten me on that.
I couldn't find it. Everything I found only said ROS1, but the full name of ROS1 is ROS proto-oncogene 1 receptor tyrosine kinase, which is a protein coding gene.
But that doesn't come up to ROS1 though.
Yeah, so where they came up with the ROS1, I have no idea. But basically, the normal ROS1 gene fuses to part of another gene, and this causes activation or uncontrolled growth of the cells in the lungs, leading to the small cell cancer. And there are a few different types, basically 3 types of lung cancer. There are, of course, the small cell cancers. In addition, adenocarcinomas, which are the most common, squamous cell carcinoma, and squamous cell carcinoma usually begins where you'd expect to have more squamous epithelium, which would be in the bronchial tubes, whereas adenocarcinoma is usually in the outer regions of the lungs. There's also large cell carcinoma, which begins also on the outer edges of the lungs. And this tends to grow very rapidly, and patients don't have symptoms until very late. But non-small cell cancer is 80 to 85% of lung cancers. So most of them are non-small cell. The small cell is only about 10 to 15%. And it's also called oat cell cancer, is another name for small cell cancer.
You know, Jay, the thing about it with that drug right there, they said that the FDA, when they approved it, because in phase 1 and 2 trials, 79% of the patients responded.
Yeah. Yeah, which is pretty amazing.
Yeah, another set of staggering numbers. So in other words, we're getting better and better at these medications.
Yeah, they're targeting specific enzymes and specific genes that are involved in a lot of these mutations that lead to cancer.
Yeah,
and putting a stop to the metastatic, or not the metastatic, but the mitotic abnormal divisions of the cells that leads to a cancer. So let's see. That's all we have to say about that. Common adverse effects: dizziness, dysgeusia. So food tastes funny, peripheral neuropathy, constipation, dyspnea, ataxia, fatigue, cognitive disorders, and muscular weakness.
No vomiting,
and the common sites of lung cancer metastases are just like we talked about with colon cancer. Yeah. Liver, brain, lymph nodes, adrenal glands, to the bones. And so this is another group of patients, along with patients with multiple myeloma and patients with prostate cancer, metastatic prostate cancer, who are going to be placed on a bisphosphonate or similar drug.
That's right.
All right. So our next drug is Reznick. Okay. You want to tackle the
sure, we'll jump all over that.
The generic name?
Yeah. I'm gonna pass on the generic name because the Grastum, we already know Phil Grastum. Because doesn't that sound like
I know him. I think I went to med school with him. Phil Grastum.
That's what I was about
to say. Didn't he play for the Yankees?
Yeah, he may have, yeah. So, this drug is to be used for what we see with chemotherapy, neutropenia, Jay.
Yeah, which is a significant complication of chemotherapy.
Oh, absolutely. So this drug is a leukocyte growth factor that's used to reduce the duration of a febrile neutropenia in patients that are undergoing chemotherapy. And of course, that's a big concern for us. Anytime we're doing some type of invasive procedure on that patient, we've got
because they reduced immunity. Their defenses against infection are very greatly reduced, and when they have they don't always have to be febrile, and febrile is classified as a temperature over 1015 in this instance. Febrile neutropenia. That's what this drug is specifically indicated for. And it works, basically, it's a colony stimulating factor that helps stimulate the growth of neutrophils. And so it's given once per chemotherapy cycle, about 24 hours afterwards, and seems to really increase the patient's leukocyte count and neutrophil count. And you want to make sure that if you're treating a patient who has a myeloproliferative disease and they're on a drug that can cause neutropenia, that if you're going to do anything invasive, you want to make sure that you do it before their next dose of chemotherapy, close to their next dose of chemotherapy, not in the 3 weeks after.
And you're in tight communication with their oncologist or hematologist, and you're going to document that. And remember, you're going to be prescribing antibiotics after this as well, too.
Yeah, absolutely.
Document. And we have been saying for 3 years now as PharmaDocs.
Yeah, if it's not written down, it didn't happen.
That's right.
Yep. So there's febrile neutropenia, temp over 101 or 2 readings over 100.4. Yep. This is a medical emergency because the risk of bacterial infection has a very high mortality rate.
Yes.
So the kinds of carcinomas or cancers that are at risk of febrile neutropenia, low risk are solid tumors, patients that have neutropenia for less than 7 days.
That's right.
High risk would be the hematologic cancers, or if this neutropenia lasts more than 7 to 10 days. All right, and I think our last drug
right here
is Ogsiveo.
Yeah.
Nirogacestat or Gystat, and it's a gamma secretase inhibitor that's in development or has been in development for the treatment of adults with desmoid tumors. And desmoid tumors are non-cancerous growths or benign growths, but they occur in many parts of the body, the abdomen, arms, and legs. And depending on where they grow, they can put a lot of pressure on structures, put pressure, if they're in the chest, on the heart, pressure on the GI tract, and really cause the patients a lot of problem. Most of them are slowly growing, and so they don't need to be treated right away, but others can grow very quickly, almost like at the speed of a cancer, although they're not treated the same way.
Right.
But surgery is probably the mainstay, but also sometimes radiation and chemotherapy is used. But since it doesn't spread to other areas of the body, it doesn't metastasize. It's localized. And
there's one right there.
Yeah, there's one right there. You can see it on the CT scan. If you look right where the arrow is, that is a desmoid tumor in the abdomen, and you can see how it's pressing on all the structures that are underneath it. And you can see a visible bulge on the patient's skin because it's basically right under the skin. And the symptoms are based on, as I mentioned, where the tumor occurs. Most commonly, they're in the abdomen, arms, and legs, but they can form anywhere in the body. And the signs and symptoms are things like an area, a mass or swelling anywhere on the body, pain, loss of function because it's putting pressure on the nerves going to the area, cramping and diarrhea if it's pressing, if it's abdominal. And so this is a new drug that can help minimize the growth of desmoid tumors and hopefully give patients a lot of relief. And again, they occur all over the body. They can occur anywhere. In the head and neck. It's spam calling. I thought I turned that off. Lower extremities and the thorax and the abdominal wall. Anywhere in the body. All right, so that brings us now to our medical emergency of the month. And this is like any medical emergency, something that can happen any time of the day, morning, evening, anytime in your practice. Doesn't have to even be in your practice.
Right. And
symptom-wise, these patients are going to may have nausea, dizziness. They may be very pale, sweating, and
crushing chest pain that's not relieved by nitroglycerin.
So what could this medical emergency be? Crushing chest pain, dizziness and pallor,
and
nausea.
You've already given some nitroglycerin.
Yeah, and it's not getting better because you thought it was angina, but it's not. It's a myocardial infarction. And we've talked about this before. The difference between an MI, which is a heart attack, myocardial infarction, and sudden cardiac arrest. Thank you. SCA right. Is the sudden cardiac arrest is essentially an electrical problem, whereas the MI is more of a plumbing problem.
I think your next slide may show that.
Yeah, a patient who's having a heart attack is still going to be responsive and breathing. They're going to be very uncomfortable. They will still have a heartbeat. They don't need CPR or an AED yet. But they can fall into ventricular
cardiac
fibrillation.
Arrest. That's right.
Whereas someone with sudden cardiac arrest will immediately become unresponsive, no breathing, heart stopped, and needs CPR and an AED. They need to be defibrillated ASAP.
So an SCA, basically, Jay, 3 cardinal signs, symptoms: sudden loss of consciousness, no breathing, no pulse. You're going to need an AED to restart the heart.
Yeah.
Whereas with myocardial infarction, the predecessor to that is angina, chest pain.
Yeah.
All right. And then that doesn't get any better. Then we have to assume now a myocardial infarction.
Right.
Now that can progress into cardiac arrest.
Right.
Which is different
but not
than
sudden
cardiac arrest. Okay. Yeah. And so it's always important to make sure that you out there can differentiate the two.
Yeah. Yeah. So sudden, obviously sudden. A heart attack, though, can move to a cardiac arrest. And so how do we, with the signs and symptoms we mentioned were diaphoresis, sweating, chest pain, but it can also be in the arm, the neck, or the jaw, shortness of breath, feeling of indigestion, dizziness, pain between the shoulders.
And that's the difference, Jay, with men and women.
Yeah, men and women seem to have different symptoms.
Right.
For men, it's pain in the chest, arms, or neck, where for women, it's kind of a discomfort between the shoulder blades. Yes. And more so shortness of breath with women than with men. And also the unexplained fatigue and sleep disturbances, which are unique to women. So how do we treat a myocardial infarction? Call 911 immediately.
Yes.
Stop what you're doing and activate the EMS, your EMS plan. You want to make the patient comfortable. So if they're comfortable laying flat, you lay them flat. If they're comfortable sitting up, you sit them up. If they're comfortable somewhere in the middle, that's how you position them. And you give them oxygen through nasal cannula. They need oxygen because what's happening with a myocardial infarction is there's some blockage. Blood or oxygenated blood is not getting to
a specific part of the heart.
Exactly. And so it may be getting, it's going to start getting ischemic, but if you can raise their PO2 a little bit with nasal oxygen, that will give them more time. And so you're going to give them nitroglycerin, possibly. Give that kind of your first try. If that doesn't improve after 2 or 3 doses of nitroglycerin, this is a heart attack. Have them chew on aspirin and
swallow it.
4 baby aspirin, chewable baby aspirin, is a lot more palatable than a single 325 milligram aspirin.
Yes.
Yeah, because if you've ever bitten into an aspirin or put it under your tongue, it tastes nasty.
It is. And as you finish up the algorithm right there, and then you've got to make sure your team is ready. Mm-hmm. And somebody should already have the AED there, and be ready to initiate high quality CPR as well. And that's critical. You've got to be able to do that.
Yeah.
All right.
Because this can go to cardiac arrest at any time. So you got to be ready. And hopefully by the time the oxygen and the aspirin and the nitroglycerin has helped enough so they can, at least the paramedics are there and they can treat the patient and get them to the hospital, obviously ASAP.
Yeah, but you've got to call Jay early on.
Yeah, and get them to the cath lab.
Yeah,
time. It's all about time.
Yeah, the more
time is critical.
Wait, the less likelihood of EMS getting there in a timely manner for you because you hesitated in calling 911.
Yeah.
Hey, you have a medical emergency. Call 911.
Yeah, never hesitate. Never think, it's going to clear up. I'll give them 5 minutes, 10 minutes.
Great point. You're in a state of denial.
Exactly, because if it doesn't, you're not going to have a good outcome.
You just lost 5 minutes.
And if you do the right thing, immediately call 911, you may have saved the patient's life.
And your practice.
Exactly. All right. So just want to
remind you. Great program out
there
called PharmaDent.
Yeah.
15 medication categories right there in your office all day long. What did you say in the very beginning? If you want to hang upside down and swing and read it, you can do it as well.
Yeah, you can do that too. Yeah. As long as the screen doesn't flip over, right?
That's right.
You got to put it on no rotation. Right. And $99 is an incredible price for about 10 hours, 7 hours of CE. Yeah. It was $25 per module, but now it's being offered by dentallearning.net for $99 for the full course. John and I both have courses that we do together on dentallearning.net. John has a course, Anaphylaxis Update 2023, which will give you 2.25 CE units, and it's only $29. I've got a 3-hour opioid course, which will cover your state-required opioid education mandate for renewing your license in pretty much every state. California has its own specific requirements. It's only 2 hours, but you have to be a registered provider, we have a separate course that I've done for California that is approved by the board. And our IV sedation course, IV sedation training, which we think is very unique. We set out to make what we think is one of the best IV sedation courses available for dentists out there.
Yes.
The statistic is that about 90% of patients or 90% of doctors who take an IV sedation course never end up implementing it in their practice for a number of reasons. It could, they're not sure of themselves. They don't know how to set up the office. They don't know what they need to buy. Their assistants aren't trained to help them and facilitate the sedation. They don't know what monitors to buy, anything, what drugs. We do all that for you. We teach you all that. We want you to be completely comfortable with IV sedation. So we've got 75 hours of online didactic.
Yes.
Before you come for the in-person, which is another 3 days, 3 8-hour days of in-person.
Minimum 8 hours.
Which also includes a skill station, multiple skill stations with the state-of-the-art mannequins for doing
simulations then.
Yeah, simulations of anaphylaxis, of airway obstruction, myocardial infarction, sudden cardiac arrest.
The closest you'll be to the real thing.
Yeah.
Bottom line.
Mm-hmm.
We want you ready.
Yeah.
Right?
We even cover how to use a cricothyrotomy cannula. There are different types, and we show you the one that we like best, that makes it the easiest, so that if you need to do a cricothyrotomy, you know what to do. The first time that you've seen it is not the pictures in the instructions in the package.
Right. And we're not in a hurry to see how fast we can get you trained through here. Because like Jay said, we don't want you to be that statistic that doesn't do IV sedation. I mean, we have it broken down in 3 phases. Online is phase 1, in person is phase 2, and then clinicals is phase 3.
Yeah. And of course, the minimum is 20 hours. Yeah. Minimum of 20 hours in every state. But if you think that minimum 20 hours is not enough for you, you are welcome to come back and do more clinical cases.
20 patients, minimum 20
or 20 patients.
Yeah.
20 patients.
And,
not 20 hours.
And like Jay said, you can come back at any time to Vesper and get more training, and there will not be a fee to you.
Mm-hmm.
All right. So we want you comfortable. All right.
Yeah.
And then what the great thing about is, once a month afterwards, we have what we call is our Vesper Nation get together. Everybody that's gone through the course, we all get together and talk about last month's cases.
Mm-hmm.
All right.
So, what have you had in your office? What do you have questions about? What's come up?
That's right. Run
Which
stuff
is great.
by us. All right. We're all about making you a better dentist, elevating your practice. Introduction of IV sedation is a game changer.
Yeah.
I promise you.
It will change the nature of your practice for the better.
Yes.
And we even train your assistants so they know what to do to help you. And we basically, it's a soup to nuts course. We give you everything you need to know to be comfortable starting and basically changing your practice to become an IV sedation practice, where you're going to treat the 20% of the population that does not go to the dentist because of fear and anxiety or medical issues.
And one thing Jay and I also talked about is that we're going to be there the entire time during the in-person didactics. I mean, Jay and I are there. We feed off each other. We support each other. It's all about getting you ready. For the 3 days in didactics, we're right there by your side.
Yeah.
We're not leaving you. Okay.
And for the clinical cases, you don't go to the hospital and have an anesthesiologist with 5 people standing around. They all start an IV, and that's their experience.
No.
We have IV sedation trained general dentists on our faculty, and they will be your one-on-one mentors for your 20 cases. And not only are you going to do 30-minute cases, but you're going to learn how to manage an hour-long case and a 2-hour-long case with IV sedation, which is very unique.
That's right. Everything you're doing in your practice right now, you're going to see it with a fellow colleague that's already IV sedation certified.
Mm-hmm. And does what you do. They're a general dentist doing IV sedation.
Right. It's not what Jay and I do. It's what you do every day.
Exactly. All right. So thanks for your attention, everybody. Our next episode of PharmaDocs will be on Friday, January 12th. Same time. 2024, wow. 3 p.m. on the West Coast, 6 p.m. on the East Coast. We're going to have probably about a dozen new drugs to cover, and a new medical emergency of the month, as well as anything in pharmacology news that we think might be interesting for you all to know about.
Thank you so very much, and Happy New Year. See you in the new year.
Yeah, have a great holiday, great New Year, and we will see you back in January. Let's see, where are we? There we go.